Good morning, everyone. Welcome to the first keynote session that we've got today at the Joint Contact and NNPCF conference. As you all know, this year is a little bit different. We can't be with you in person. My name is Mrunal Sisodia, and I'm one of the co-chairs of the National Network of Parent Care Forums. And today, I'm really pleased to have the pleasure of having a conversation with Russell Viner, Professor Russell Viner, and I'll be putting some of the questions that you have sent in to us to Russell. We also have a chat box and a question function you should have available. So if you have any questions for Russell as we go, please put them in and we'll do our best to address them. So with no further ado, I'll pass over to you, Russell, to say a few words of introduction.
Thanks, Mrunal, and good morning, everybody. I'm really pleased to be here. This one is I like the idea of having a conversation rather than me having to give a lecture. We thought I would just give a couple of minutes at the start to tell you who I am and what I do, and then Mrunal's going to ask me questions on your behalf. So look, I'm a paediatrician. I see patients every week still, though I have a range of other jobs. One of them is as president of the Royal College of Paediatrics and Child Health, and that's the professional body for paediatricians in the UK. We have nearly about 20,000 members, actually internationally across the world. We also have a very strong advocacy campaigning arm. So in many senses, we are one of the peak voices for children and young people's health. I I'm part of the NHS Transformation Board for Children and Young People. I'm the vice chair of that board, and I was very pleased to be involved with helping to think through the long-term plan for the NHS in England to get children and young people into that plan and actually be part of the system that starts to try and change things for children and young people. So I'm hugely pleased about that. I'm also a member, or I chair the Stakeholder Council for the Transformation Board, which is where I've met Mrunal, or met him more recently, because we've certainly met in the past. And I'm also a member of the NHS Assembly, which is the NHS England trying to listen to a range of people from patient advocates, patients themselves, parents, carers, through to healthcare workers, academics, etc. During this COVID epidemic, we've done in the college a huge amount of work with all of the, NHS England, Public Health England, Department for Education, trying to focus on protecting children and young people. And I've been part of Bits of SAGE, so the scientific group for emergencies, in that providing some advice to government on what they should do about children and young people. My work on SAGE has not been the bigger picture, when to lock down and how to do it stuff. It's been only focused on children and young people. And my particular focus there has been around schools and COVID in the broader sense. So Mrunal, I think so my clinical expertise, back when I started as a paediatrician involved in diabetes in particular. I have a real focus on young people's health as much as children. So in fact, my title is Professor of Adolescent Health. But certainly for the last 10, 15 years, I think my focus has been really very broad across children and young people's health, making the arguments for them in policy and public health. Mrunal, over to you.
Thank you, Russell. That's great, and it's just interesting, a couple of parallels between what you said there and your role and what we do at the NNPCF. You talk about a membership of 20,000, and our membership this year is likely to be edging towards 100,000. Wow. And whilst that's an incredible privilege, I sometimes describe it as having 100,000 bosses, which is the issue with having it. We are very proud to be a membership-led organisation. Yes. And I think it's very funny when people sometimes draw the pyramid of the NNPCF with the co-chairs at the top, and I say, absolutely not. We're the guys at the bottom. We spend a lot of time listening, and also a lot of parallels in what you said there around providing a voice for children and young people's health, and that's really one of our major roles. Can we start with coronavirus? Because obviously we can't get away from that this year, and hangs over everything. It's shaded everything that we've done. And I just wanted to just get from you the real, no nonsense. What are the basics around it, in the sense of, do children catch it? How poorly are they when they get it? And how infectious are they? Those are the three big things I think that it would be really useful if you could just talk through your, the latest understanding of those three big questions.
Absolutely. No, key questions and well put. So firstly, do they catch it? And the answer is yes, they do. And I think we've been on a journey with this. And I wanted to start by saying that was one of the interesting things I saw recently published in the British Medical Journal was a viewpoint from a man called George Davy Smith, who said, the more certain someone is about coronavirus, the less you should trust them. So I'm going to be a little bit certain, but not too certain. And it's certainly true that for children and young people, our understanding has really changed right from the beginning. Right at the beginning of the epidemic, the reports we got from China, from Italy, from Iran, were that children weren't affected, that they didn't catch it, that they weren't affected at all. And so there's some myths around right at the beginning that children didn't catch it and they didn't pass it on. What we now know is that children do catch this virus, SARS-CoV-2, which is the virus that causes COVID-19, but they almost never get severely ill, and they're incredibly unlikely to get so ill that they might be at risk of dying. And I'll come back to that. So it's incredibly rare that they get really very ill. What we have realized is that children and teenagers catch it a lot more than we had realized. So that's because they're generally asymptomatic. Asymptomatic means have no symptoms. So it's very possible that, in fact, we know probably about 20% of adults have no symptoms at all when they catch COVID. So, they might have had a bit of a headache one day, but they'd really never noticed it. They may have had nothing at all. You test them later, there's evidence they were infected. Actually, for children and teenagers, that's probably about 80% of them. Somewhere 60 to 80%, we think, have no symptoms, or the absolute such minimal symptoms they're not noticed. So that explains that slight kind of what looks like a paradox, which is, early on we thought children didn't catch it, but you've probably been reading in the news that the highest group with the highest infection rate right at this moment are actually older teenagers. Younger children have lower infection rates than the older teenagers, but they're still quite up there. And one of the funny things about this second pandemic wave has been, apparently funny things, has been looking at the data on who gets infected, and it looking like teenagers and children have higher infection rates than the elderly, which is totally the reverse of what we saw for the first wave. And that's just because we're testing in a different way. In the first wave, we only tested people who had symptoms, and it's children almost never get symptoms, so they didn't get tested. We didn't think they had it. If you do population screening, you test everyone in the population, you find a lot of infection amongst children we didn't know about. Okay. I'll come on to the transmission question because that's clearly key. But there is quite a bit of infection out there, but it doesn't affect children. They have no symptoms. They're incredibly unlikely to get sick. Now, of course, the question is which children are likely to get sick and how frequently. Now, we think, so firstly, members will know that there have been, very sadly, over 50,000 deaths of adults in the UK due to COVID-19. Hugely sad figures. We think our best knowledge is that there's probably around 25 children and young people that have died with COVID. And I say with, not from, Mrunal, and I think that's really important. Because there's no doubt when something is around as commonly as COVID, sadly we know that children and young people die. Around 5,000 children and young people die in this country every year. A really big number, far too many. A lot of them are premature babies who die in the first day, week, or month of life. But there's, probably 1,500 other children and young people who die. And some of those happened to be infected by COVID when sadly they died. So that's the with bit. People who die of COVID, I don't think we have an exact guess, but I think our best estimate is probably 10 to 12. And the signal that we get, what we understand is that probably the only conditions that put you at real risk of very severe illness and death are children who have a combination, and some of your children will be in this group, I do understand that, who have a combination of severe neurodisability and respiratory or lung problems. So that might be a young person with, for example, very severe cerebral palsy or severe neurodisability who also has a tracheostomy and needs assisted ventilation. We know that some of those young people are at higher risk. However, we also know that they were at higher risk of being carried away by influenza, the flu, in most winters. And in fact, if we
that's a really interesting comparison, also, because I think I read somewhere, I think it might have been on the Royal College's website, that actually the mortality rates for children for COVID are very similar to seasonal flu.
Yeah. So firstly, there's been no change to our overall children's mortality rate. COVID, as you know, has affected the adult mortality rate, but actually for children, it hasn't shifted, because mortality from car accidents and a whole range of other things are down. So COVID has, there's a little bit there from COVID, but we lose on average 16 young people in a winter to seasonal influenza. Now, it's one of the things I think most people just do not know. We see the flu or influenza as something that's just ordinary, a bad cold. And actually, the truth is, it carries off around 16 young people every year on average. Some years worse, some years better. So in that sense, I think our understanding is those young people who are on assisted ventilation, severe neurodisability, they're very vulnerable, probably to any type of winter virus. And there's some sense in which COVID is just another one for them. Now, there is this thing called PIMS-TS. Members have probably heard about the fact that back in May, we discovered a relatively new condition that appears to be linked to COVID that we think has affected around 250 children across the UK. That's when the body's immune system, which is what we fight disease with, totally overreacts, and overreacts to such an extent that it starts to damage other parts of the body, such as the heart, in particular, or the blood vessels or the brain, or the skin. So the good news is great majority, in fact, almost all of those children and young people were successfully treated and went home. We believe that probably 2 children, 2 to 3, died as a result of PIMS-TS. It appears to be, as I said, an overreaction of the immune system. The risk factors for PIMS-TS we don't really know as yet, but we don't think that they're related to neurodisability or special needs at all. We think it's probably more of a genetic issue with an immune system that's programmed to overreact. Does that make sense? So very few children. So I was going to say the 2 signals we know about are people with severe neurodisability plus lung problems. So it doesn't seem to be just neurodisability or just lung problems. In fact, there's some evidence that children with asthma seem less likely to get COVID. It's only one study. I'm not sure that's true.
Right, okay.
But there's some interesting issues out there. Children with cystic fibrosis, for example, don't seem to have a higher risk from COVID. Cystic fibrosis is a severe lung problem. Children with diabetes, so the things that are there in adults, it's possible that severe obesity increases your risk of COVID like it does in adults. The trouble is there just haven't been enough children getting very ill for us to tell that.
Yeah.
Diabetes in children doesn't, and we're pretty certain about that, doesn't give you the same problems for COVID as diabetes in adults does. Down syndrome in children doesn't give you the same problem as Down syndrome in adults does, and that's really important. There have been no deaths that we know of in the UK or anywhere across Europe, or no severely ill children with Down syndrome under 18. whereas, as you probably know, there's been some reports in adults.
Yeah, and actually, I actually do want to return to Down syndrome a little bit a little later in our conversation, but can we return to the question around what we know about how infectious children are?
Yes, of course.
There's the issue that a lot of our members are worried about, which is their children themselves, but also a lot of our members are worried about those children who live with other vulnerable people.
Yeah. So I think my take on it, and I'll come back to the transmission question very specifically. My take on it is that actually for children and young people, the risks of COVID are incredibly low, about the same as for seasonal flu, which is, it doesn't say there's no risk, but actually incredibly low. Okay, transmission, do they pass it on? Well, we've been through a real journey on this, let me tell you. And people were saying right at the beginning that children didn't transmit. Well, that was clearly nonsense right at the beginning. We know children are less susceptible to catching it. Even though they catch it quite a lot, biologically, they're less likely to catch it. But because they mix a lot, children are constantly mixing with each other, even if they're less likely to catch it, because they mix a lot, they have higher infection rates. I think the jury is still out on transmission. I think there are some possibilities that they are slightly less infectious. Sorry, that they are less infectious than adults, that they are the same as adults. There's no evidence that they are more infectious than adults.
So it's clear that what is clear is that they're because children are super spreaders when it comes to flu, right?
Yeah. So,
and there's no evidence that they are at the moment super spreaders when it comes to COVID.
No, look, and it's really interesting, this one. We tend to see children as, I mean, well, you know, in the medical terms, we would say vectors of disease. Lots of people see children as, and forgive me, slightly dirty, mucky animals that spread a lot of disease. Young children, you know, spit, cough, poo, you know, all of that. And children do a lot of mixing, etc., etc. So there's a lot of doctors around in particular who see children as super spreaders of everything. And what's also interesting about schools and nurseries, we know that when you put lots of children together, there's a lot of spread of seasonal flu, there's spread of lice, you know, nits, there's spread of impetigo, there's spread of measles. You know, some of these childhood diseases, nurseries and schools are really good at spreading. What's interesting about COVID is that we're not seeing that. The jury is still out, but we're confident that children are not super spreaders and that schools are not these incubators of disease like they are for other conditions. And we don't really know why that is.
That's really important, isn't it, when it comes to decisions around schools being open or otherwise? Okay, thank you.
There is transmission in school. There absolutely is. It's not to say there isn't, but what we don't see is that schools amplify the pandemic. To a great extent, particularly for younger children, particularly in primary schools. There's more evidence recently. I think there's new evidence out. We've had to readjust some of our thinking and recognize that teenagers, particularly older teenagers, are playing quite a role in spread. And there is evidence that teenagers, when community infection rates are high, infection rates in school are high. And as I said, we don't think that's because schools are amplifying, but if infection is high in the community, it naturally comes into schools because everybody has it. And then teenagers will bring that back to households. There's no doubt about that. But we don't think it's an amplifier. And the effect is much, much less for primary schools. And again, I think we've had to readjust our understanding of that for teenagers over the last month as new data came out. However, a lot of thinking about this and balancing this in SAGE and, you know, more broadly across the whole country, I think there's a really strong consensus that schools should stay open, but we need to be careful with all of that. And I'm proud that as a country we've got to that situation, because let me tell you, there are countries in Europe where the pubs and restaurants are open and the schools are shut. And I think, you know, as a, you know, advocate for children's health, I'm just appalled by that idea. But there are countries in Europe where that's the case.
Yes, and I agree with you that it talks a little bit about the value set of a nation, isn't it? And
So,
whilst I do miss a pint, let's be clear about that. I do definitely miss a pint. I'd rather have the schools open. I think you've touched on this, Russell, but can we just be very explicit now and say that actually there seems to be a clear differentiation between the older that children get,
yep,
or infectious and
yep.
Impacted by the virus they are. Is that a fair?
That's our current understanding. It's not securely based on all of the science in the world, and I'm disappointed we're still in that situation 9 months into this pandemic. And I can certainly say that there's a lot of thinking happening about, how do we get the data to really give us the answers on this? And there are studies starting up. There are other studies really looking at this. I think, as I said, this pandemic constantly surprises us. So the other thing on transmission, and you're probably going to ask me this. So we don't think, so children aren't super spreaders, and we actually think that schools play quite a limited role in transmission. There's something about schools and the way that schools control children's behavior, are quite containing environments,
yes,
across a range of environments, that we don't think there's a lot of evidence that schools amplify and transmit a lot. And actually schools, particularly primary schools, may damp down transmission. But transmission can occur between children, and children can clearly bring an infection back from school to parents. What do we know? We know that it's possible, we know that it happens, and we know that there's some, that older teenagers, there's evidence that they're bringing infection back to households more than we thought. We don't have that for primary schools.
right.
There's lots of people ask me questions about, vulnerable adults in the family, about extended families, adults with, who are clinically vulnerable, and the risks to them. And unfortunately, they're largely unanswerable questions. And I think my view is that we have to see these things in the round. If we only focused on COVID, you're probably not asking me this question, but if we only focused on COVID, we might close everything that we do in society down.
Yes.
Put ourselves in straitjackets, our children in prison, in a sense, in houses or schools, not let anybody socialize. Wait till the virus has gone away. It ain't going away anywhere anytime soon. Hope we might have a vaccine by the middle of next year for a lot of the population, sure. But if we close everything down and wait till the middle of next year, we will have a very damaged children's generation and no economy or society left. And I think it's somehow a balance there.
And just to explore that point a little bit further, as in, what sort of impact have you seen? Because I think that we've talked so far about the direct impact of COVID upon children. Can we talk a little bit about the
indirect
impact of our response to COVID on children? The indirect impact. What have you seen there? Because I think our members have certainly seen an impact.
Yeah, and it's interesting. I speak about this so much all the time, and it's interesting. Even we have just slightly fallen into the trap of, talking about the COVID bit. Actually, the impact of COVID on children is, I'd characterize it as collateral damage.
Yeah.
People know the term collateral damage. That's, in warfare, where you're aiming your rockets at the enemy, but actually you kill all the civilians in the town next to where you are aiming. And those civilians are collateral damage. And that's what children have been during this pandemic. Our attempts to control the virus and save the lives of the middle-aged and elderly, as a middle-aged, well, slightly elderly person, I value that. Our efforts to do that have really produced collateral damage for our children and young people. We started to see this early on. I talked to you before about deaths of children and young people with COVID. Back in April, May, at the beginning of this, we knew about around 8 to 10 deaths of children and young people with COVID, April, May, June. But we also knew about just as many deaths of children where their treating paediatrician said, I am 100% sure that the delay in getting to hospital contributed to this very sad death of this child. And that's death from things like meningitis, sepsis, that kind of infection, or very late presentations with cancer symptoms, like brain tumor, that kind of thing. So even right at the beginning, we were seeing probably as many children dying from the way we essentially shut down the health service, and parents and everybody obeyed the government, stay home, protect the NHS. They didn't bring their children. So there was the delayed presentation harms. We think through lots of different effort by people and lots of education campaigns and things, we think that's gone. We don't think that's now harming children. What else did we do in the first pandemic wave? We stood down the protective, the barricades we put around our children, that we've spent 100 years building up in this country, many countries. So that's health visitors, social workers, schools, all of the things that we put in place, community physiotherapy, occupational therapy, community nursing, all the things that we have built up to protect our children, we stood down with little regard to those children. All the focus was on protecting the middle-aged and elderly. And it was probably the right thing to do at the time. But I think one of the issues is we must not ever do it again. And that's one of the areas we've been in the college very active on. Whenever I get to see a minister or Simon Stevens or people at the top of the NHS, it's we must not do this again. The stand down bit, send all our health visitors off to white bottoms in intensive care. That's really important that somebody does that, but don't make our health visitors do it.
And there was definitely a sense from our cohort that many of our children are already disadvantaged in many ways,
and they were more disadvantaged.
And COVID just doubled down on that disadvantage. In a decision made to protect the elderly and vulnerable and the middle-aged.
Look, I think
that certainly came through in the experiences of our families who during lockdown was some of them were quite shocking and appalling, but and even those that coped really relatively well during lockdown had a singularly much more difficult time than they otherwise would have done.
I think that's true. And there was the sense, as there always is, that community services were deprioritized because everybody focused on the acute, which is the right here and now, the sharp end, the emergency. We found that with our pediatricians. We got our acute pediatricians, the ones manning the emergency departments, back much quicker than we got our community pediatricians back, because there was just a sense that community was less important. And as you know, community pediatricians and community nurses.
We are still finding it. We have reports from up and down the country that a lot of community-based therapy services, the occupational therapists, the speech and language therapists, the physiotherapists, are still not fully restored across the country, and certainly any backlog that has built up has not been addressed yet.
So
have you seen any impact? Can we talk a little bit about the impact when it comes to things such as obesity and mental health?
Yeah, I was going to come on to those. Yeah. So look, that's the health service, or the disease, the presentation, the health bit. There's also been all of the other impacts on our children's lives. Our children need social contact. Schools are incredibly important for them for a whole range of things. The anxiety and concerns of the pandemic really played on them. There's very good evidence that there was worsening mental health amongst children and teenagers during the pandemic. There's a bit of unusual evidence there. I think we know that for some teenagers in particular, staying off school, being at home, some teenagers were happier. We have to accept that. But actually, for the great majority, we have evidence of harms. And there's incredibly robust evidence to show that from big national surveys. In fact, they did a big national survey in 2017 of mental health, and they found that 1 in 8 to 9 young people had a significant, young people that were 5 to kind of 16-year-olds. 1 in 9 had a significant mental health problem. They did it again in July. It was 1 in 6.
Right.
So that's quite an increase in terms of mental health problems. One of the real concerns we saw early on was a rise in the suicide rate amongst under 18-year-olds. The most distressing thing to ever think about, talk about for any parent, probably for any adult, is for a young person to take their own life. We started to hear some reports from the National Child Mortality Database of a potential rise from mid-April. We convened a group with NHS England to not to sit on it, to watch it, because it would have been disastrous for us to see 1 or 2 weeks of data to go into the press. And actually, one of the issues is we know there can be copycats. We know that overreacting to suicide can be a problem. So we tracked it for about a month to really be clear that this was what we call a signal, not noise. And it did drop a couple of weeks. We thought, oh, it's okay. Came back up again. But by mid-May, we had enough evidence to say, I'd already made sure the Chief Medical Officer knew about it. I'd already made sure, we'd made sure as a group that the Prime Minister knew about this. I think it was one of the, it had an impact on the decision to reopen schools, because actually in May could have gone either way. Getting schools reopened, we were part of that real fight to get primary schools in particular reopened. So hugely sad data. It was about a 40% increase. 25 young people took their lives during that February through to late May period. And around half of those, there's good evidence that young people were really worried by the lockdown and COVID.
Yeah, yeah.
So,
can we just return to around just the direct impact of COVID, and really around the measures that we should be taking, in particular around special needs and those with additional needs. Can you say something about which children should be isolating, and in particular, we had a lot of concern around the clarity around the shift between the approximately 100,000 children that were asked to isolate or at the early part of the pandemic, and now now that list is very much smaller. I understand there's about 10,000 children are being asked to isolate in the clinically extremely vulnerable. Can you say a little bit about the clinically extremely vulnerable group?
Hopefully no one's being asked to isolate per se in a kind of full-on way. And we have a strong belief that given the data we have showed, that there is essentially pretty much no child who really should be isolated from all other children and not go to school. I think that the exception to that is probably a child with very active cancer treatment who is very immunosuppressed. A child who's presented with leukemia, they are treated with some very strong chemotherapy that knocks their immune system right down, and they're very vulnerable. Clearly, we have always managed them in isolation during that treatment, so we need to be very careful about them. The young people I talked about before, who might have severe neurodisability and lung problems, long-term ventilation. Again, I think we know that they're at higher risk from seasonal influenza or this virus this time. Should they be isolating, not going to school and all those sorts of things? I don't think we really think that's the case. We think that schools, we need to make sure that there's the balance in life, because actually the benefits to them of more normal life almost certainly outweighs this slight increased risk from COVID.
And that just to drill into that, Ross, just be really clear on that. And that includes so we're talking about not only the very vulnerable children with complex needs, but also you're talking about those that attend special schools with the much greater physical contact that they may come across there, the personal care that's required there. It includes categorical that.
But what we have a responsibility to do is to make sure, we as a society, to make sure that those special schools, those special schools, A, protect the staff, and B, protect the young people in terms of aerosol generating procedures and places. One of the important things to know is, where's the most dangerous place for anybody to catch COVID? And the answer is probably in an intensive care unit treating very, very sick COVID patients. And actually the evidence shows that the nurses and doctors and others in intensive care have a very low risk of catching COVID. I suppose that what that shows is that risk reduction really works. It's about protecting themselves. I'm not the right person to give you the exact level of PPE, personal protection, that person X or person Y should do in the situation in this special school or in this aerosol generating procedure and those sorts of things. I know that they are complex areas. I know that many groups have been working with Public Health England and DFE about that over time. I do very much recognise that. I'm not the right person to give you the specific exact detail of who wears what and when. But I think the important thing to know is that, this virus, it's not a clever virus. Basic, really good protection really works, is the answer.
Okay.
Where do we know doctors and nurses have got sick or died from COVID? And, well, healthcare workers, I should say. It's actually mostly people, it's not people in intensive care. It's not people in the emergency department where you go if you're getting sick with COVID. So it's not the high-risk places. They get sick in the low-risk places because people aren't focusing on basic protection.
Yes.
It's probably similar. Yeah, we think it's similar across a range of areas.
Can we talk about sort of Down syndrome specifically, because I think that we and many others were really caught on the hop by the categorization of over 18s with Down syndrome as clinically extremely vulnerable. Now, our membership covers that 0 to 25 age group for children with and young people with special educational needs and additional needs, and that categorization really caught us on the hop and caught many services on the hop and led to the shutdown again, or unilateral shutdown of many services for young people with learning disabilities and Down syndrome in that period. What can you share around that?
So, I think we were caught on the hop by it as well. We had suddenly got news. So we had been looking, when I say we, that's, child health professionals, the college, we had been looking at the issue of, all children significant with, disabilities, disability, whatever, over time, and had not seen any signal from this. We got wind of the fact that there had been an analysis done showing a higher risk of mortality in Down syndrome. So we saw some urgent clarification, and it became clear that it was only in older adults. And so I'm not claiming that we got the clarification, but it became clear that, as I understand it, the risk. So I'm not talking here about children with an untreated heart condition, because I think that's, if there's Down syndrome and you have an untreated heart condition, which some, well, if young people with Down syndrome have a treated heart condition, but if there was a very untreated heart condition, they might be at a different risk category. But straight up, young people with Down syndrome, we clarified that the risk appears to be similar to many of the other mortality risks in Down syndrome. Now, this is not my area of direct expertise, but what I understand the biology is that that young to middle-aged adults with Down syndrome often have diseases that will come on in the whole population and at a later age come on in kind of early to middle age in Down syndrome. There appears to be a, you could almost call it a premature aging type of, I use the word pathology, biology there. And that's what happens. We see that happen with a range of conditions in young people, young adults with Down syndrome. And what we understand from this is that we're probably seeing a similar thing, is that some of the risk that we normally see in the 70 and 80-year-olds, we're seeing in adults with Down syndrome at a much earlier age. For example, I'm quoting 40 to 50, but I don't want to upset or worry any parents there. But so we're seeing that the same kind of age shift down. What we're not seeing is it going anywhere near young adults and children. Now, I think they put an age 18 cutoff in there because that's how they define children compared with adults.
That is exactly the representation we have made as well. Yes.
I don't believe there's any evidence that young people with Down syndrome, for example, 18 to 25, are at higher risk. But I think when I say they, I don't think the NHS is trying to do the right thing. It's trying to identify a group that's at higher risk. It, in a clunky way, says children aren't, adults are. Standard definition is 18. We're going for that. And as a college, children and young people, we can't influence or unable to influence beyond that. But as I said, I know of no issue in teenagers or young adults with Down syndrome.
Thank you. And just to be clear, we have made very similar representations, and we read that in the same way as the very simple adulthood starts at 18, and therefore this is a very broad. It's a very broad brush.
Yeah.
Or mixing my metaphors, it's a sledgehammer to crack a nut approach to this. Can we talk a little bit about the vaccine? We've had some questions really around the vaccination of children, and in particular, whether the two real questions. Just where will children be in the vaccination priority order list? And particularly, we've had this question around the children, young people with learning disabilities and autism, because there's been some very disturbing evidence that of their mortality rate in comparison to the rest of the population.
In adults, absolutely.
And then also just a little bit about, is the vaccine safe for children, particularly those our children who may be on a more complex drug regimes, and how does it interact? Has that testing been done around the other conditions and other drugs?
Absolutely, really good questions. And I know quite a bit about the vaccines, but I'm not an expert. And what's one of the things, just to start, one of the interesting things is the people who are leading the vaccine studies in this country are mostly paediatricians. So Professor Andy Pollard, who is leading the Oxford vaccine, is a paediatrician and an advisor to us. And in fact, he's head of what's called the JCVI, which makes decisions on vaccines, though yesterday. But so coming back to the question.
Joint Committee on Vaccinations and
Immunisation, that's right. Though he's had to stand aside at the moment from the JCVI because he can't chair a committee that recommends his own vaccine. Anyway, so children will, at the moment, and I see no chance of this changing, children will be last to be vaccinated. All children as a group. And that's because of what we talked about before, is that they are at almost no risk as a group from this vaccine. We and a number of others, and potentially I imagine yourselves, have made representations to the Chief Medical Officer and others that children with special needs, so significant learning disability, those at higher risk, the groups I talked about before, should be pushed up the vaccine priority risk. Chris Whitty's response, I'm sure he won't mind me saying, is two. Number one, he doesn't make that decision, it's the JCVI, which is this joint committee we talked about. And actually what I admire them, what the government is trying to do is take the politics out of this. So Boris doesn't get to decide, and the First Minister in Wales and Scotland doesn't get to decide who gets the vaccine. It's done on a very scientific basis by risk. And it's by risk at the moment that they're deciding to do it. And by risk, children will be at the bottom. Now, we will continue to make these arguments that there's a very small number of children who were at higher risk. and we think they should.
For example, with the flu vaccine each year, there's a group of children that are prioritised for that, and families of children that children are prioritised.
Well, all children up to year 7 should be vaccinated against the flu, and because they're super spreaders. So you vaccinate them first, as well as the elderly. So again, it's that difference here. Now, Chris, so the second thing that Chris Whitty has said, every time you want to push somebody up the list, someone else will fall down the list. And that's a balance that JCVI will have to make, but just be aware when you're pushing for your special group to go up the list, you'll be pushing someone else's special group down the list. And I get that. So I don't make the decision, the JCVI does. There are 2 ways of making the decision. Number 1, based on risk, or number 2, based on protection for the population. What I mean by that is, there's a lot of children, they play some role in transmission. We don't think there's super spreaders, etc., etc., etc. But you could argue that you should be immunizing the whole population, that this risk-based stratification is pointless, that you should be in there immunizing children because actually, they can transmit, and until they're an immunized group, they will transmit to some extent. So I think what I understand is when we don't have enough vaccines, they're going on a risk stratification, but as soon as more vaccines available, they'll immunize the entire population. I can't see children being vaccinated before the summer, to be honest. It is possible otherwise, but I think unlikely. Right. So the really interesting question about vaccine safety, the first answer is we don't know, but trials are underway. Well, they are doing some trials of the Oxford vaccine, at least in children. So the children are different. Children's immune systems are different. In fact, it is thought that one of the reasons that children get such a mild version of COVID, if they get it at all, is that their bodies are already primed and they have a good immune system. Their immune system is already primed because of all the colds they catch and things. So it's possible that they'll have just a very good response to the vaccine and it'll be highly protective. There's a minor possibility that they'll respond in different ways that we don't understand. There's no reason to think the vaccine shouldn't be safe.
But essentially, we will have to wait and see what the trials and the evidence shows. Can I want to move us away from coronavirus, and that's been a really clear description of the situation that we're facing there. Can we talk a little bit about, spend the next 10 minutes or so talking just a little bit about the long-term plan?
Yeah.
There's a lot in the long-term plan that is very good and very necessary for children with additional needs, with special education needs and disabilities. The special education needs and disabilities work stream, the learning disability and autism work stream, the mental health work stream. These are all front and center to the concerns that our families and the lives that our families lead all the time. Can you talk a little bit about, tell us a little bit about to what extent the long-term plan is almost is being rebooted, and you're following COVID, and your ambitions to get that rolling again?
Yes. So I think, like you, we were exceptionally pleased to see children and young people in the long-term plan. Actually, the first time
conspicuously absent from the 5-year forward view.
Oh, yeah, mentioned 3 times. First time for 15 years that we've had children as a priority, and huge reason for enthusiasm, I think. Sorry, somebody's banging on my front door and no one else in the house is going to answer it, but I shall ignore it. What was I going to say? The long-term plan, yeah, so hugely pleased about that. And the long-term plan had a series, there was 37 different commitments in that, and as we say, some real commitments about children with disability, with special needs, which were very welcome. Everything's been sideswiped by COVID. I mean, I think in a sense we put the health service into a hard handbrake turn. during COVID, and it hasn't fully recovered. So we work closely with the NHS on this. They are absolutely cognizant, you know, they do know that they need to firstly re-examine the things that we said we would do, because it's 2 years ago now, and actually what's been achieved, what needs to be different. So there needs to be a re-examination, but there needs to be an acceleration of actually getting it into place and delivery. And I'm frankly a bit worried about our capacity to do that, given the fact that we're coming into another COVID winter, given the stretch I see in everybody's systems. This is not a criticism of colleagues in NHS England. I think they're brilliant and they're working incredibly hard. But I think, you know, those of us in your group and the college, we need to keep up our pressure on NHS England to make sure they deliver on this. We need to be understanding and recognise that they've got an impossibility at the moment, a really busy winter coming up. I think we have to hold their feet to the fire to, as I said, never again stand down the services. That's the least we can expect from this winter. Can we expect improvements over this winter? I think we need to see them starting to focus on that. We need to see and help them get the processes in place to restart. Transformation is the word that NHS England uses, which is improvement in any other words. We need to see the plans for that and some signs that that's going to run quickly once this COVID emergency is over. We mustn't let things stall again. None of them want to do that, but the capacity in the system, I mean, you know, there's a national clinical director, Simon Kenny, who's brilliant, and there's 2 national clinical advisors, Michelle McLaughlin, who's a nurse, and Matthew Clark, who's a paediatrician. And the national clinical advisors, I think, are paid 1 day a week. I mean, they're clearly working 4. Simon Kenny, I think, is paid 3 days a week to do this job and is clearly working about 10 days a week. So, because, there's just so much for them to do. There are good signs. NHS England has delivered on the money. There's a lot bigger team now in the Children and Young People's programme. As I said, we need to help them make sure they can deliver this.
And a couple of sort of very specific areas from our membership is that that I think that the learning disability and autism program has really restarted, and we're starting to see lots and lots of evidence of that, of activity on the ground. And we are, we in our membership are being pulled into lots and lots of work there, which is great, which creates other problems for us with those of capacity. But at a national level, can you say a little bit about representation of parents in particular on the national board, the Children and Young People's Board? Because at the moment, my understanding is that we have it's great that we've got children and young people on that board, and that voice is being heard, but we are noticeably lacking parental engagement at that board.
And there is a commitment to address that. And I think the focus has been on making sure children and young people's voices were heard. And that's, I think NHS England has done a lot on that. They have put money into it. They've put quite a lot of focus on it. And I think there is a recognition that parents' voices are separately important. And in fact, I will hear more about that next week. No, Wednesday, I think. There's a transformation board meeting. And thank you for reminding me to ask where that's up to.
From the message we get very clearly from our membership is really, there's 2 groups of children who cannot represent themselves. Those who are either young or don't have capacity. And also, I think that one of the big messages that come through is that parents and children say different things, which is the heart of parenting, isn't it? It's the heart of the conflict with the young people. And it's really important that those different things are heard and given equal value.
One of the things I would say is I'm also a member of this thing called the NHS Assembly. Now, the NHS Assembly is an unusual body. It was formed about 2 years ago as part of the long-term plan process, and its supposed to be a representation of broader healthcare society, and it's about both helping NHS England and holding it to account for delivery of the long-term plan. And there are definitely parent representatives on the assembly. There's a number of people with, and I know this because I hear them speak very passionately, a number of people who represent constituencies such as children with SEND, children, young people with disabilities, parents and carers. And actually, carers in particular have been quite a focus of the NHS Assembly. I've had to drag them back to parents a few times and point out, anyway, I won't go into that in great detail, that there are some differences because a lot of it was focusing on carers of the frail elderly.
Yes. Yes.
And they often forgot about parent carers of children and young people. But I think that's a group where parent voice is definitely heard, and I think that right at the top of the NHS, Simon Stevens and others really listen to the Academy, the Assembly.
Yeah.
So, but yeah, I will ask on Wednesday.
No, that's good. I think I'm mindful of time. We have spent a very I think it's been a really interesting, informative hour, Russell. It's flown by, and hopefully our
yeah, I was going to say I'm a bit shocked it's an hour, but
people who've joined us will no doubt have found it really, really useful and informative. And I think you've really helped us to update on some of the latest thinking and knowledge around where we are with coronavirus, and also a little bit of time casting forward to where we might be of the coming months and years, both with vaccines and with the long-term plan. Yep. Is there any final messages you'd like to give to our membership before we wrap up?
I suppose the final message is that keeping schools open, I think, has been one of the great achievements that our community has done. I think it's not been easy. I recognise the sensitivities, I recognise the complexity, particularly for some of your members, Mrunal. I do very much recognise that. I think I've seen the NHS, PHE, even DFE work in different ways, be much more open, much more able to change rapidly than they have been in the past. I think one of the things we have to do as outsiders who help push them and work with them is to make sure they retain that openness of working. I think that's one thing. And I think for children and young people, it's always remembering that COVID is actually the direct infection stuff. We can't let that dominate. It's got to be about the whole child and the whole family. Thank you.
That's a really good place to leave it, because that's very much our mantra as well. Please, please, please continue to work with children, young people, and their families, and see the whole child, not the diagnosis. Thank you, Russell. I think it's been a really, really useful session. I think our members will find it.
Thank you all for listening.
And we've had a lot of attendees today listening in as we've been chatting. But I am absolutely confident that we will get many more who will watch this back over the coming weeks. So thank you for your time, and I look forward to seeing you on one of our future meetings. Yes.
Thanks.
Thank you. Goodbye, everybody. Thanks for joining us.